I like to walk around, but I'm going to do my best standing behind the podium. Sorry about that. So thank you all for being here. I know that I'm the last lecturer of the day, which usually is a really challenging position to be in, but I promise I'll do my very best. And the reason why evolution of asthma is because 30 plus years ago, as a medical student, I was in a class and a pulmonologist came in and said, asthma is completely shifted. The paradigm of asthma has changed dramatically because previously we taught asthma as the ABCs. Aminophylline, beta agonist, and thirdly was corticosteroids. And that paradigm flipped. Now, fast forward 30 years, and now what we're doing is we're not just treating inflammation, but we're trying to prevent inflammation, which is, again, another paradigm shift. And that has been possible because of all these biologics that are available. So that's the reason why I named it the evolution of asthma. And I should tell you that I did a grand rounds about 3 years ago, and so all of my slides are going to be evidence-based, and some of them are going to be from the GINA guidelines, and some are going to be from the NAEPP guidelines, which is the US guidelines for asthma. And I thought that this is prime time to go over some of the changes in asthma and the way we treat it, particularly the guidelines. So some of you know that I'm a breast cancer survivor, and as a result of that, I feel like I got a second chance in life, so I pray before I lecture. So if you'll indulge me, Heavenly Father, Lord, I just pray for each person that's here, especially the medical providers, Lord. I pray, Lord, that you would give them the tools that they need to be amazing at what they do. But I also pray for their health, because the last few years have really taken its toll on us as medical providers. So I pray, Jesus, give them health, prosperity, financial blessings, and especially the healing that they need. Give them the tools, Lord, and the words to be able to speak into their patients' lives and make a difference every day. In Jesus' name, amen. Okay, so thank you for that. And she told me all the things I need to do. I've got to advance my slides. Ha! There we go. So I do have a conflict. I'm a speaker for AstraZeneca and Amgen with a product called Tezepelumab or Tezspire. But it's not going to interfere with this talk at all. So these are my objectives. And by the way, I have probably 60 slides, and if any of you have attended my lectures before, you know that I don't go through every single slide. I might pull out one salient point from each slide, so don't panic as we go through it. So asthma, we know, is a heterogeneous disease, and that's one of the things that has been discovered, and that's why we're treating asthma differently today than we did several years ago. The other thing that I want you to note is that the symptoms vary over time, and you have seen that with your asthma patients. The burden of asthma has unfortunately just gotten worse. It's not gotten better. Despite the fact that now we have biologics available, we have all kinds of great medications to treat it, but still the burden of asthma has unfortunately increased. One of the things that I wanted to, do I have a pointer on here?
Is the little green star at the bottom there, the middle of the clicker.
Ah. Oh, hello. Now, I know you told me it's better, so can I move this? If I point on there, will you be able to see it? Oh, my gosh, look at this technology. I love it. Okay, so the thing that I want to point out is that it is still the leading cause of disease, chronic illness in children, and oh, it doesn't show up. Okay, so much for the technology. Okay, so it is a leading chronic disease in children still. In fact, children are 3 times more likely to be absent from school than any other chronic disease. More technology. Okay, I think I'm on. All right, this is a little better for me. Okay. Asthma deaths, unfortunately, continue to rise, which is just a real problem. So here's the other point that I wanted to make here, is that adults are 6 times more likely to die than children. So that's most people in this room treat adults, so that's one thing we need to be aware of. And then when gender is factored in, black females have the highest rate of fatality due to asthma. So that's also going to be a problem. We don't think about that, but some of our unfortunately, some people are definitely at higher risk than others, and that's going to be an important point to look at. This is one of the best slides I've ever come across regarding normal pathology and abnormal pathology. Well, it's not pathology if it's normal. But I want you to look at this, the pathophys. I will tell you that you see this CRTH2, there was a medication that came in a pill form that they tried to use for the treatment of severe asthma. Unfortunately, it failed. But I want you to look at all the different mediators here, these inflammatory mediators that are involved in the treatment of asthma. And you're going to see, I'm going to go over some of these alarmins, TSLP, IL-25 and IL-33. I'm going to go over those when I talk about some of the biologics. But many of the mediators on here you may be familiar with: IL-5, IL-4, IL-6, I don't see it right now, IL-13. A lot of these biologics target those particular mediators, which is going to be extremely important. But look at this. This is fabulous. This is a normal airway, and then here you can see what happens with asthma. Remember, we described asthma is characterized by inflammatory changes, as well as variability in symptoms, but also mucus plugging is a real problem. Can you see all this mucus in here? It's causing that lumen to become very, very narrowed. You can see how the smooth muscle and the hyperresponsiveness is occurring in this tissue out here. So the epithelial tissue has now been discovered, and we call it the brain of the cell, the epithelial tissue. So you're going to hear more and more about epithelial tissue. Not a lot from me today. So we know asthma is a complex disease. We also know that you may have come across these two terms in the literature, these phenotypes or endotypes. And many of the literature is going to be talking more about the phenotypes. I put this slide in here because I wanted you to see the difference between phenotypes and endotypes. Lots of people use them interchangeably, but they really are very distinct. But what you really want to pay attention to are the phenotypes. And the phenotype is like, we've got green eyes or blue eyes or brown hair. So when it comes to asthma, the phenotypes are allergic asthma or obesity. Some of you have probably heard of eosinophilic asthma, and that is going to direct the way we treat asthma if someone has eosinophils or not. So then the endotypes is something called TH high and TH low inflammation. And you probably won't need to know much about that, except that if you dig into the details, you will find that people that have TH high and TH low disease have a different prevalence and a different type of asthma. I love this slide because one of the things that we have looked at is what has increased. People ask me all the time, why is asthma on the rise? Why is food allergy increasing? Why are more people having problems with these allergic diseases? So we thought it was due to what we call the hygiene hypothesis, which I'm going to talk about in just a second. But we know it's microbes. And we found that in Sweden in particular, when people were growing up on a farm, people lived above their animals, they got these LPSs or these endotoxins, and they were less likely to develop asthma or allergic disease. So we found that microbes definitely play a role in this. So the hygiene hypothesis says when we increase vaccinations and when we take more antibiotics, it directly leads to a decrease in our immune system, which is a problem, because we know that the immune system is extremely important for not just fighting diseases, as well as keeping us healthy, but also maintaining homeostasis in the body. So I want you to look at this. The new hygiene hypothesis, this is the revised hygiene hypothesis, which says that the clean environment, so the more hermetically sealed our homes are, the more likely we are to develop allergic diseases. What? Yep, that's exactly right. So unfortunately, that is exactly what's happening because we have tried to nice and tightly seal our homes, keep everybody as clean as possible, and we found out it's backfired. So unfortunately, that's what we learned, is that the clean environments, and here's what they think the reason is, it's failed to educate the immune system to launch its defense system. So now we've got a lazy immune system that doesn't know what to do. So what does it do? It shunts to allergic disease. So now we've got allergic rhinitis, we've got atopic dermatitis, we have food allergies, we have asthma. All right, that's a problem. So what do we do about that? Well, we educate us so that we know what to do. So here it is, the new hypothesis, that the friendly microbes, not the infectious pathogens, are definitely what we need to integrate into the body. I am not going to go into any more detail of this, except to tell you that this is some of the data that we have discovered over the years. Here's the thing that I wanted to point out on this one, that RSV, if you have RSV between the ages of 2 and 6 months, it increases your risk of asthma. Here's another one. How many of you are gynecologists in here? So if the more C-sections that are performed, the more likely a person is going to have asthma. I just learned that a few years ago, and I thought, oh my goodness, isn't that something? So that's what we, the OB-GYNs, need to tell their patients. If they do a C-section because of convenience, it may increase his child's risk of having asthma. Remember, asthma is a potentially life-threatening, incurable disease. And if there's something we can do to prevent it, we need to do that. Okay, so this is a Th2 high and the Th2 low, and this is what I wanted to point out to you. If you have a Th2 high asthma, it tends to be more severe. Also, there is typically eosinophils that are involved. Does anybody know what an eosinophil is? Who does know what an eosinophil is? Okay, I don't see any hands raised, so I'm going to tell you. So eosinophils are part of the white blood system. So white blood cells, there are several different types of white blood cells. One of those types is an eosinophil. And this is how I explain it to my patients because of eosinophilic asthma and eosinophilic esophagitis. So the eosinophils, what they do, if you have a parasitic infection, what those eosinophils will do, they will find their way, get into the parasite, and then they will degranulate. When they do that, these toxic granules come out and are released. They embed themselves in that parasite, and poof, the parasite explodes. Essentially, it dies. The same thing happens in the human body. So when a person has eosinophilic asthma, those eosinophils will go into the lung tissue, degranulates, those toxic granules are released, they embed themselves in the lung tissue, and we see swelling. So that is why eosinophils are such a problem, and not just for asthma, but there's a lot of eosinophilic diseases out there. EOE, eosinophilic esophagitis, is a very common one that we're seeing, again, increasing, possibly because of that modified hygiene hypothesis. So, triggers of allergic asthma. I am not going to go into a lot of detail on this. Sometimes, if any of you have been in my lectures before, I usually do a riddle. I play a game, Who Am I? And we're not going to do that today for the sake of time. But I'm going to show you some of the IgE-mediated triggers for asthma. And my favorite, this is a house dust mite. And house dust mites, you may not know, can trigger and cause atopic dermatitis. So even when little kids come into the office who have eczema, and by the way, there is a biologic that just got approved for children age 6 months, an injectable medicine. So what we do is we'll test these kids for dust mites and see if they're dust mite allergic. And if they are, then at least, I'm not going to put them on shots at age 6 months. But I will talk to them about avoidant measures. And the avoidant measures are dust mite covers on the mattress, box spring pillow, washing the sheets in hot water, take carpet out of the bedroom, and keeping humidity at less than 50%. Also trying to get rid of dust collectors, which causes the kids to scream because they have about 50 different stuffed animals in their bed sometimes, so that can be a challenge. If you just do one thing, it's not going to be helpful, so you need to do multiple different avoidant measures to make it successful. I just had to show you this because I'm an allergist. And then here is also, I have a confession. I can hold a snake, I can hold a spider, I can hold any kind of insect. I hate cockroaches. And the only kind of cockroach, and I don't think I could do this either, but the only kind of cockroach that I want to see, but I thought for fair balance, I'm going to show you a cockroach. But these are cockroaches. There's 3,000 different species of them, and there are 3 main types. We test for 2 of them in the office, but this is the only way I want to see a cockroach, and not in my mouth, by the way. Isn't that great? I just love that. So I had to show that to you. So here are some of the non-IgE-mediated triggers for asthma. So we know the IgE-mediated ones, that's allergy, right? But the non-IgE-mediated ones, the ones that you may not think about, are going to be pregnancy, so hormones for sure. Irritants, and when I talk about the irritants, I'll tell my patients cigarette smoke, cologne, perfume, strong smells, sprays, diesel, gasoline, potpourris, plugins, pollutants, even pollen can be an irritant. So the irritants can really be a problem when it comes to asthma. The other thing is exercise. We don't think about that much, but exercise can definitely be a trigger. We know that about 90% of people who have asthma have exercise-induced bronchospasm. The other one that people tend not to think much about, high emotion, cold air, and reflux. So if there's a lot of cold air outside, a person can definitely get triggered. They'll tell me, especially when I'm running outside and it's cool, it causes me to have a hard time breathing. Yep, that's a trigger. So notable. High emotion, and what I frequently ask is, when you laugh really hard, does it make you cough? And if it does, you need to be digging a little deeper, because you want to ask those questions, because you don't want to miss something like that. Okay, I brought this one up because, again, obesity is a phenotype, and obesity can be a problem. And what we have discovered, again, in this field of allergy, asthma, immunology, it is one of the most difficult to treat types of asthma. And these people who have obesity also tend to be hospitalized more. Whoops, I didn't mean to do that. Oh, no, how do I go backwards? Help, help. Oh, wow, I did it. 4 to 6-fold increased risk of hospitalization. So that can be a problem. So if you have patients who have obesity, you want to make sure that you're looking at asthma and get them under good control. Also, they tend not to do as well on ICSs, inhaled corticosteroids. So these are the folks that may require a little more of your attention and a little more of your time. So here, I'm not going to go over this. Most of you know how to treat obesity. So the diagnosis of asthma, and this is going to be one of the most important things that we look at, a 12% or greater improvement in the FEV1 following a bronchodilator, and a 200 milliliter improvement. So if you don't see both of those things, it may not be asthma, but there is also probability, because how many of you have spirometers in your office? Ooh, I love that. That is great. So if you have a spirometer in your office, then you can perform these studies and see if your patient does have asthma, make that appropriate diagnosis. But even if you don't have a spirometer in your office, here are the probabilities. And this data is part of the GINA guidelines, but these are the things that will show a heightened probability of whether or not your patient has asthma, even if you don't have spirometry in your office. But I am a strong proponent of making a clear diagnosis of asthma, because several things can mimic asthma. It's not on here, and I'm not going to go through it, but I'm just going to tell you one of the things that I see more commonly is VCD, or vocal cord dysfunction. When a person comes in and they're wheezing like crazy, and they tell you that they've been on steroids multiple times, they've been to the ED multiple times, but it turns out they have vocal cord dysfunction, and it's not asthma at all. And yet, they are treated with these drugs that can cause high morbidity. So it's important to know that. If you did spirometry and their lung function is completely normal, and they tell you that they use their rescue inhaler and it doesn't make a bit of difference, it's probably VCD. Also, irritants is a common trigger for them. So this is really what I'm going to go over today, is some of these guidelines, because the guidelines have dramatically changed. So the good news is that we have guidelines that will help teach us and help guide us as to how to treat asthma, but they have changed dramatically. So this is the one I referred to earlier, the NAEPP. So this is National Asthma Education Prevention Program, and the other one is the GINA guidelines. The NAEPP is the one that we usually follow in the United States. The GINA guidelines is global. So that's the one that sometimes we follow and sometimes we don't. People just pick and choose which one they want to do. The problem is that some of the medications on the GINA guidelines are not necessarily readily available in the US. So it's made it more difficult to follow the GINA guidelines. But I want you to be aware of some of the changes. So actually, you're familiar with this institute, the National Heart, Lung, and Blood Institute, also known as, again, the NAEPP, was designed in 1989. And they have done multiple EPRs, expert panel reports. So it's a bunch of people that come together that are trained, and they've decided, based on what's in the literature and even what's not, what is going to be the best plan for these folks. So that's how these guidelines come to pass. So GINA was also developed by WHO, the World Health Organization, and the NHLBI. So you would think that they would be very similar, but there actually is quite a bit of difference between the two. I'm not going to go over that. So this is, again, the evolution of it, because you can see all these expert panel reports that initially came out in 1991, then 97, then 2002, and then look, there was almost 20 years. One of the comments I want to make here is, previously we didn't look at domain and risk. We just looked at the classification of asthma, and then we treated accordingly. But then they decided to add the risk factor, because the risk is extremely important, because we know that a person who has high risk for asthma is more likely to end up in the ED, hospitalized, and be on oral steroids. And oral steroids by themselves, once or twice in a year, means that they are not well controlled. But 3 times in a year, listen to this, means that they are poorly controlled. And we don't want to have asthma patients that are poorly controlled. We want our asthmatics to be extremely well controlled. That's why it's important to look back at your chart, and if you see that your patient has been on not inhaled, but oral corticosteroids, whether by injection or a dose pack, you need to get a little deeper dig and to see what's going on. Look at some of those triggers, get them tested, see what else you can do to minimize that morbidity. So then the EPR, 2007, there was a report, and then the most updated report came out in 2020. And then GINA, 2017 and 2022. And this is what I want to go over with you. So the first step is identifying someone has asthma. And the way that you do that is you look at the symptoms, you can do or not do spirometry, but then you want to classify asthma. And there are multiple different graphs out there, but this is one of the ones that I thought would be the easiest to go through. So this is, again, and there are 3 different groups, 0 to 4 years old, 5 to 11-year-old, and over 12-year-old. So this is the over 12-year-old group. So I want you to look at, here is the classification, and then this is all impairment, and this is risk. And the risk, as I mentioned to you, here it is. They say greater than 2 oral steroids in a year increases their risk of morbidity significantly, which is a problem. But I want you to look at this. Again, I will tell you that the GINA guidelines do not have intermittent asthma as a classification anymore. They just have mild, moderate, and severe. But remember the rule of 2s? Do you remember learning about the rule of 2s? 2 beta agonists using 2 if they have symptoms more than twice in a day, if they're waking up more than twice in a month, if they are using their rescue inhaler frequently, again, more than twice in a week except before exercise, then that's going to be a problem, and that changes their classification. The reason why it might be important to know about the classification is because it directs your treatment, and that's exactly what you're looking to do, is direct treatment. So I want you to, again, I'm not going to go through every single step, but I just want you to be aware of it. So again, I mentioned to you that the GINA guidelines took a little different spin on it. In fact, when they decided to classify patients, they did it retrospectively. So what they did was, after you had the patient well controlled, then they said, okay, now what type of asthma do they have? Now how do we classify it? Is it mild, moderate, or severe? Where what we do, and what we still do in our office, is we look to see what their lung function looks like, and if their FEV1 is less than 80%, that tells me at least they're moderate. And if they have symptoms, it may worsen their category, but we treat right then and claim it's something, so we'll say it's mild, moderate, or severe at that first day without waiting for them to be on medications and then reclassify it. But the GINA guidelines, they reclassified it. So who's at risk for mild asthma? This was, I think this may be an eye-opener for some people, because I want you to look at this. 37% of patients who are considered mild, remember mild means that their FEV1 is greater than 80%, so it's normal. And I want to make a point on that too, because frequently I will see patients that come in and they will say, my doctor told me I don't have asthma. Okay, why is that? Because my lung function was normal. But know that 100% of people with mild asthma have normal lung function. So just because the lung function is normal doesn't mean they don't have asthma, which is why you have to look at those symptoms as well. So that's one point I want to make. The other thing is, look at this. So these are people with mild asthma. 37% of them will have an acute episode. 16% will have a near-fatal episode of asthma, and 15 to 20% of them will die of asthma, of these folks. So it is concerned, these are ones that have the severe reaction or the severe exacerbation. So it's important not just to classify them as mild asthma, but to know that even people who have mild asthma can die from asthma. So that's the take-home point here. So how do you decide when to change guidelines? So what happened is there were 2 trials, the Sigma 1 and Sigma 2 trials were performed. And these trials showed a couple of things that were interesting. What they found was, these again, the GINA guidelines, they found that if you have a SABA, and a SABA is albuterol, short-acting beta agonist, they compared it to an inhaled corticosteroid with formoterol. And if you are not familiar with formoterol, formoterol is a LABA, a long-acting beta agonist, which is in Dulera and Symbicort, if you know those trade names better. So what they did, and they recommended, now here is one of the biggest changes, they've recommended that they not use a SABA anymore, so we don't use albuterol anymore, but we use an ICS and formoterol instead of our albuterol as an as-needed therapy. So there was studies that was published in 2018. Let me say that again. So the Sigma 1 and Sigma 2 trials came out, and what they found is we have been using albuterol for 50 years. 50 years. And what they decided was albuterol has not been shown to decrease exacerbations, has not been shown to decrease hospitalizations, has not been shown to decrease death. So now they've taken 50 years, they've taken another look at that and decided what we need to do is change the way we're thinking about albuterol. So the Sigma 1 and the Sigma 2 trials, they looked at this. And what they did is they compared a SABA by itself to an ICS, any ICS, by the way. So that would be fluticasone, mometasone, budesonide, any of those with formoterol. That's the drug that they looked at. And they found that it was superior to using a SABA by itself. But more than that, here's what it showed. It showed that it increased exacerbation rates were decreased, hospitalizations were decreased, morbidity was decreased, and mortality was decreased. So this is going to be a big change. That now there is not going to be a place, there may not be a place for albuterol. Now, why is that going to be a problem? I'll tell you why that's going to be a problem, because albuterol still is a pretty inexpensive medicine. So now we're going to have to write for a dual agent that's going to be more expensive, so the patient may not be able to afford it. So that is going to be a problem. But I want you to stay tuned, because this is the wave of the future. This is what's going to happen. So here's the Sigma 2 trials, and they did the same thing. And in these trials, they looked specifically, like I told you, at budesonide and formoterol, and they found similar findings. So they found that it was non-inferior to budesonide maintenance therapy. So what they did is they took budesonide and formoterol, and this makes sense to me, and they compared it to budesonide by itself. So adding a LABA definitely made their lung function better, but it also decreased exacerbations. And remember what I told you? That 30 years ago, they said the paradigm shift was such that the #1 thing that we're focusing on is inflammation. But I want you to look at this, because budesonide by itself, with budesonide and formoterol, was non-inferior, and they all showed an increase, or a decrease rather, in the inhaled corticosteroid usage, and the side effect profile was less. So again, we are again coming into a new revolution of changes in the treatment of asthma. So what they looked at, what are the risks of SABA-only treatment? So this is one of the things that they looked at. The adverse events occurred, but what do SABAs actually do? And sometimes when a patient comes into the office and we bronchodilate them to see if they may have asthma, we look at their lung function pre and post, and sometimes their FEV1 has decreased. And part of the reason for that is because of this. There's beta receptor downregulation with the use of albuterol that you may not be aware of. There's also decreased bronchoprotection. So sometimes albuterol, and it can cause a rebound hyperresponsiveness, and it can cause a decreased bronchodilator response. So we know that albuterol, although we've used it for 50 years, unfortunately has some problems with it. And that's why another paradigm shift is happening in this field. So they also found that higher use of SABA is associated with adverse clinical outcomes, which is not surprising. And we know that inhaled corticosteroids reduce the risk of asthma deaths, hospitalizations, exacerbations. We know that. But part of the reason why albuterol is used so readily is because it works in 15 minutes. So people immediately feel better. And so that gives them that false sense that they are doing better when actually the inflammation is not being touched at all. And that's one of the things that I will go over with my patients in the office, is I'll show them the picture of an inflamed airway and one that isn't inflamed, and I'll tell them, your albuterol that you're using 6 times a day, it's doing nothing to get rid of this swelling inside your airway. That's a problem. And so sometimes they get it, but they go, but doc, you know what? It makes me feel better. It works. Okay, so we've got a problem, but it may be solved. I'm going to show you something else. So they call this the SMART approach or the SMART therapy. So the SMART therapy, and this again is going to be something that it's going to take time, but this is for me, this is the first audience I'm talking to about this, and I will tell you that there are still plenty of allergists out there and pulmonologists that are treating the old way, that haven't incorporated these changes. But I want you to be aware of them because these changes are going to be taking place, and I want you to be in the lead. I want you to spearhead this because it can make a difference with your patients. So I want you to look at this. So again, the SMART therapy means a single inhaler for both maintenance and rescue. So that would be the Formoterol with an ICS, for an example. The treatment also contains 2 medications, like we said. Formoterol is the one that was studied with any ICS. Also, the data indicates that combining the maintenance and the rescue therapies offers better asthma control. So did you hear what I said? So look at this one. A maximum of 8 puffs. This is for the combination, the dual inhaler, for children 5 to 11, and 12 puffs for children 12 and over. So if someone is using their combination agent as maintenance, they can still use their combination medicine for rescue. Are you following me? So they can still use instead of using albuterol by itself, we're talking about using a dual inhaler for rescue because of the decreased exacerbations, morbidity, mortality, etc. I think I went through this. I'm going to go to the next one. And what they did, what Gina did, is it broke it into 2 tracks, and I want you to see the 2 tracks. So the first track is when you use a low-dose ICS or inhaled corticosteroid, any one of your choice, with Formoterol as a reliever. That is considered the preferred strategy when it comes to the treatment of asthma. The track 2 is where you use the SABA as a reliever, and it's an alternative approach, but the reasons why they don't recommend it is because it's less effective, because of all the reasons that I mentioned several times already. So then there are other options. And one of those that I think you need to know, and I don't know if any of you have ever used chromones, which is Nadocromil or Intel. Well, those medicines are no longer available globally, unfortunately, because they were really helpful with exercise-induced asthma. So here are some of the other key changes that I'm not going to go over in lots of detail because I want to be able to get to the biologics. And then these are some of the other changes, and here's a comment I just made about chromones. They're not available anymore. So again, this is comprehensive changes that I want you to be aware of, but the big ones are going to be the SABA use. So I don't know, and that's the other point. When I was preparing this lecture, I really wanted to see what the recommendations were for exercise-induced asthma. And this is an older data, this is 2013, but even with that, when it comes to exercise-induced bronchospasm, the recommendation is if you have an athlete that's working out 5 or 6 times a week, then you do want to use a combination inhaler with them. And this is older data, but it's going to come to the light even more in the next couple of years. So what you want to do when people have exercise-induced bronchospasm, and about 10% of people will have exercise-induced bronchospasm and not have asthma at all. It's purely exercise-induced, so there's no inflammation. It's all that, for the sake of this conversation today, it's just that smooth muscle tightening when it comes to exertional activity. So here is what this is from, again, the American Thoracic Society, and these are some of the things that they looked at and found that if someone has to have that medication, that albuterol, frequently, we need to be rethinking that. We may need to put them on an ICS daily, or we want to do that track 1 where you're adding an ICS to their SABA if you're going to continue using a SABA. So I'm not going to talk about, how much time do I have? What time is it? How long have I been talking? I have another 30 minutes? Okay. I may come back to that, but I really want to talk about the biologics. So the asthma biologics, actually, the one that's been around the longest is, anybody know? Yes, Xolair. Xolair has been around since 2003. And Xolair, as you know, was the first one that was indicated for allergic asthma. So it's a Genentech drug, and it's for children now, less than 6 or greater than 6 years old, 6 years old and older. And you have to have an IgE level between 30 and 700. Sometimes we'll have patients that will come in and their IgE level will be 1,000 or 2,000, so we have challenges trying to get that medicine approved for them, but we frequently can. And then in the pediatric group, it goes to 6 to 18, and their level can be even higher, 30 to 1,300. Xolair now has an indication for nasal polyposis. So chronic rhinosinusitis with nasal polyposis, and so that is for people who are 18 years and above. And at this point, it seems like we have half and half. About half of our patients who are on Xolair are on it because of chronic idiopathic urticaria, or chronic spontaneous urticaria is a new nomenclature. And that is usually going to be about the same dose. It's anywhere from 150 to 375, and it's every 4 weeks, and it's indicated for kids 12 and up. So kids and adults, which is great because forever we never had a good treatment for urticaria. And I will just go over for you, what do the guidelines say about the treatment of urticaria? The recommendation is that you start with a histamine 2 receptor and you quadruple the dose. So that's usually where you start, by quadrupling the dose. And I usually tell my patients, start with 1. If it doesn't do it, go 1 twice a day. If that doesn't do it, do 2 in the morning and 1 at night. If that doesn't do it, do 2 and 2. And then if that doesn't do it, then we usually add an H1 blocker, or an H2 blocker rather, which is going to be your Pepcid. But did I tell you to use an H2 initially? I'm sorry, it was H1 blocker. So we always tell them to do a second generation H1 blocker, which is going to be Zyrtec, Allegra, Xolair, not Xolair, Xyzal. Those are the medications I'm referring to. So here is the mechanism, and I think that it is fascinating to know exactly where it is working. May not be fascinating to you, but it is to me. So here is omalizumab, which is Xolair, and here is going to be your plasma cell from which all antibodies come from, and here is going to be IgE. So what Xolair does, it's going to bind that free IgE. So if you have any that is you will not decrease, you may not decrease the IgE completely because it's not getting rid of the bound and the unbound. And so therefore, you still may have some IgE, and therefore you still can have some breakthrough when it comes to hives, or asthma for that matter. Sincair. Many of you may not have heard about this drug, but this is where we talked about the eosinophils. Remember I talked to you a little bit about eosinophils? So eosinophils, the way eosinophils are, the way they mature, the way they move is because of 2 major cytokines, IL-5 and IL-6. And those come from the bone marrow. So what happens is when those IL-5 and IL-6, actually the eosinophils are in the bone marrow, the IL-5 and IL-6 will recruit those eosinophils to come out of the bone marrow and go to the different cells in the body, different areas in the body, and that's going to be an important point. But IL-5 and IL-6 play a role in maturation of the eosinophils, proliferation of the eosinophils, activation of the eosinophils, and chemotaxis. So if you have a medicine like Sincair, what it's designed to do, well, I can show you right now. What it's designed to do is designed to bind or block IL-5. And IL-5, again, is that extremely important cytokine that plays a role in maturation, proliferation, activation, as well as chemotaxis of eosinophils. And you can see it's binding right here. So here is the drug. And if you block that IL-5 with Sincair, and Sincair is an infusion, so many people are not familiar with this one. So it blocks it, and then if you don't have the binding, then you don't get what we call signal transduction. If you don't have Sincair on board, then it will stimulate a reaction, a cascade of events, and then you'll get signal transduction. Nucala works exactly the same way as Sincair. Exactly the same way. And this medicine is indicated for people greater than 6 years old, 6 years and greater. So it's used to treat severe eosinophilic asthma, but it's also designed to treat what we used to call Churg-Strauss, or a type of vasculitis, eosinophilic granulomatosis with polyangiitis. It also has an indication for nasal polyposis. And you have to have an eosinophil count at least of 150 if you're going to put somebody on this particular medication. And if their levels are lower than that, they will not get approved by insurance companies. So it's important that we look at those eosinophil levels. It is now, a pen is now available, so patients can actually take this medicine at home, administer it at home, unlike the Sync Air, which you can't do. And Xolair just got some approval. If you select the right patient, they can also have their Xolair at home. Fasenra. Some of you may have heard of Fasenra. Fasenra is also a biologic, but it works a little bit differently. Actually, it also binds up IL-5, but it binds up eosinophils using IL-5, but I want to show you this. So its mechanism of action is slightly different because here is benralizumab or Fasenra. It's going to bind to the high affinity receptor on the NK cell, and it's going to bind to the eosinophils. So when it binds to the eosinophil, it doesn't allow for that cascade of events to occur. It doesn't allow that eosinophil to degranulate and those toxic granules come out and cause problems. But it also will cause a reaction in the NK cell, or the natural killer cell. Again, one very important component of the defense system. And it releases these granzymes and perforins, and it causes what we call eosinophil apoptosis. Now, for any of you that may not remember that term, apoptosis, it just refers to programmed cell death. So what it does is interferes with that. So by two different mechanisms, it actually stops inflammatory mediators from getting released. Now, the truth is that when the pharmaceutical reps come in and they want to compare Fasenra to Nucala, for an example, or to another biologic, I ask them because they say, we've got two different mechanisms of action. Like, okay, cool. Tell me about the clinical relevance. They can't, because there's no data that shows that their product is superior to one of those other IL-5 blockers, so they can't show me that, and we don't know if there's any clinical relevance to it. Now is the newest player on the team. No, this isn't the newest one, but this is Dupixent. Dupixent has blown everybody away. Has anybody used Dupixent? Has anybody used Dupixent in their practice? Okay, we got one, just one person? Okay, we got a couple. So Dupixent is what I'm calling a blockbuster drug, and I'll tell you why. Because the indications just keep on coming. It's incredible. So dupilumab is now dosed down to age 6 months for atopic dermatitis. So kids that have severe atopic dermatitis, and believe it or not, I've put kids on this drug, and it is life-changing for these kids. I had a little guy, before it was indicated for children 6 months of age, I had a child that it was dosed down to 6 years old, and I put this little fellow on it who had severe eczema, severe. He had oozing and weeping, and his skin was horrible. He couldn't sleep at night because he's scratching all night long. It was awful. So I talked to the family about it, and I said, you know, we get samples. We can try this medicine. It is an injection. It typically is every 2 weeks, but for kids his age, we can try and go to every 4 weeks. His skin, I wish I had thought about, I have permission to use his slide. I didn't make it into a slide. I wish I had now. It was absolutely life-changing. When he was in preschool, and he drew a picture of, it was Thanksgiving, he drew a picture of a turkey, and he had with his hand, and there were 5 different things, and he was supposed to put down the things he's thankful for. So this is a 4-year-old, and he was thankful that he wasn't itching anymore. Oh, are you kidding me? That was just heartbreaking. But the great news is it made a huge difference in his life, and now it's indicated down for kids that are 6 months of age. So it's making a huge difference. So the other thing that it's good for is severe asthma. I'm not going to go into the dosing. But here was the amazing thing. The second point, eosinophilic esophagitis. The reason why I say this is amazing is because eosinophilic esophagitis bases its diagnosis on the number of eosinophils. So if you have a certain number of eosinophils per high-powered field, there's a diagnosis of eosinophilic esophagitis. So they did the studies, and they wanted to know how effective Fasenra was, benralizumab. They wanted to know how effective Nucala was. And they found that it wasn't effective at all. Very not clinically relevant at all. Now, this is an eosinophilic disease, and we are downregulating the eosinophils, but the medicine's not working. Why? But what medicine worked? Dupilumab. Dupilumab binds IL-4 and IL-13. IL-4 is the antibody responsible for allergy. And IL-13 is responsible for, again, some other inflammatory mediators. But I think we named it wrong. It shouldn't be eosinophilic esophagitis because even people who had 0 eosinophils are still having symptoms of EoE. So there is something to this dupilumab, the IL-13 in particular, that we just don't know about. And it also works for prurigo nodularis. But here is a mechanism. IL-4 is extremely important to allergists because IL-4 is the antibody responsible for allergy. So if you don't have IL-4, you can't have IgE. If you don't have IgE, you can't have allergy. So dupilumab or Dupixent blocks IL-4. You can't have IL-4 when you're on Dupixent. No IL-4, no allergy. But it works for EoE. Everybody's puzzled. We don't know why that is. But the point is that's what's going on with dupilumab. Tezepelumab is the newest player on the block. And tezepelumab works up here. So here is the epithelial tissue. I told you about the brain of the cell is the epithelial tissue now. And there are something called alarmins. There are 3 alarmins, and TSLP, or thymostromal lipofuscin, is that alarmin. And that alarmin plays a role much higher up, and it releases these inflammatory mediators and causes inflammation. So TSLP, when we block TSLP, then what you have is a decrease in IL-13, IL-4. You can't see IL-5 on here, but it blocks also IL-4 and 5. So it also is going to be a drug that has definitely been proven to be helpful for a couple of reasons. One is because you don't need a biomarker. So to treat somebody with any of these biologics, you need biomarkers. This is the only one that you don't need a biomarker for. And it is, again, another biologic that you probably will be seeing more and more of. And because now there, again, is a pen that's available, these patients can take their medicines at home as well. So if you've got patients that have severe asthma, if you're not comfortable using the biologics, you can call me. I'll walk you right through it. Or you can try it on your own and see how your patients do. And I promise you that they will be significantly better. So when do you refer to an asthma specialist? These are, if you have unmet needs, then you want to refer to a specialist. And here is the 2 big points I wanted to make. If they need allergen immunotherapy or allergy shots, you can refer. And if someone has had more than 2 bursts of corticosteroids in a year, then that's a good time to refer to an allergist as well, because we might be able to do a deep dive and try and figure out what's going on with them. So in summary, asthma is a heterogeneous disease, which has shifted the paradigm over the past 30 years and moving forward. We're walking into precision medicine, and we're going to find that there's going to be more and more biomarkers that are going to absolutely direct what biologic and what treatment is going to be the best for the patient, but we're not quite there yet. But it does have phenotypes and endotypes. Understanding that is going to be helpful for targeting the therapy. Understanding those guidelines is going to be helpful in terms of treating your patients. And again, limited use of SABA. That's going to be one of the biggest changes that you're going to have to wrap your head around. So I read the first article about this 3 years ago. I'm still wrapping my head around it. So it's not going to be an easy transition. And patients still come in and I explain all this to them about this smart therapy, and they go, "Can you still write a prescription for my albuterol?" So I think it's going to take a long time to convince people that they're not going to need their albuterol any longer. That's it. Thank you for your attention. I appreciate you.